Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for postgraduates and consultants. Today's topic is multifetal pregnancy, the important concepts with question answer format. Now, there are certain important physiological changes which do occur in multifetal gestation, such as there is exaggerated hypervolemia, more anemia because of the hypervolemia, as well as increased iron folic acid demand. Pressure changes are important with excessive uterine enlargement, which is with the uterus, as well as amniotic fluid excess also contributes for the pressure changes. Sometimes there is even renal dysfunction because of obstructive nephropathy because of these pressure changes. More of cardiac output, decreased vascular resistance, and there is a progressive diastolic dysfunction which is observed in these multifetal pregnancies, and this diastolic dysfunction reverts back to normal after delivery. There is more of nausea vomiting with increasing beta hCG levels, especially in first trimester, with more of a hyperemesis gravidarum. If you are asked what are the types of twins, we can say the first way of dividing is dizygotic and monozygotic. Monozygotic are also called as identical twins, where a single ovum is being fertilized by a single sperm, and then after a certain this fertilized ovum gets divided in two. That leads to the development of these monozygotic or identical twins. If the division occurs in first 72 hours, then it leads to the dichorionic diamniotic type of twinning, which is also called as DCDA, dichorionic diamniotic. Whenever the division takes place before for in less than 4 days, or from 0 to 3 days, or within 72 hours of fertilization. Now these dizygotic twins are also called as fraternal twins. Here two separate ova are being fertilized by two separate sperms, and there is a ultimately it also leads to the development of two placentae, which might be seen as separate placental tissue, or it can look like a single placenta because of the fusion of these two placentae. There are two chorionic layers and there are two amniotic layers. So two placenta, two placentae, two, this red area is the chorion. Two chorionic tissues, green is amnion, two amniotic tissues. Then this is called as a dichorionic diamniotic. So dizygotic pregnancy is usually leading to dichorionic diamniotic. Monozygotic pregnancy will lead to diamniotic dichorionic, provided division of the fertilized ovum is taking place within first 72 hours. If division takes place in 4 to 8 days of fertilization, it leads to the development of this type of a twinning, where there is a single placenta, so we call it as and there is a single chorionic layer, so we call it as a monochorionic, but there are two amniotic sacs. So it leads to the 4 to 8 days is the time period when the fertilized ovum is getting divided. It leads to the development of monochorionic diamniotic twin pregnancy. Here there is a single placenta. So if we see the intervening membrane, what it will show is only presence of two amniotic layers. Whereas when we saw that diamniotic dichorionic, here there are two amniotic layers with the in between chorionic layer, which was seen in the previous slide. Intervening membrane. So if intervening membrane is examined, we can differentiate between this, whether it is a chorionic diamniotic pregnancy or whether it is a monochorionic diamniotic pregnancy. Post delivery, after the delivery, when we examine the placenta and with careful observation of the membranes, intervening membrane, if we find there are three layers, these three layers in diamniotic dichorionic will be seen because of the presence of fused chorionic tissue in between these amniotic layers. Whereas here, whenever it is a diamniotic but monochorionic, single placenta and no chorionic tissue in between. If we examine the intervening membrane, there are only two layers of amnion which are seen, AA. If division occurs still later, from 8 to 12 days, it will lead to the development of monochorionic monoamniotic pregnancy. And rarely, if the division occurs even after 13 days of the fertilization, it leads to the development of conjoined twins. So, if depending on the number of zygotes, two zygotes, it is dizygotic, single, it is monozygotic. Dizygotic is usually dichorionic diamniotic. We have already seen how it occurs. Monozygotic, fertilized ovum is getting divided in less than 3 days. It leads to chorionic diamniotic. Monozygotic twin, a monozygotic pregnancy, that is a fertilized ovum is getting divided in 4 to 8 days period. It leads to the formation of monochorionic diamniotic pregnancy, and greater than 8 days it will lead to monochorionic monoamniotic, and still after 13 days it will lead to the formation of conjoined twins. In DCDA, there are number of placenta is two, but it can be these can be seen on ultrasonography as separate placental tissue, or it can sometimes there can be a confusion because this can be fused and it will look like a single placenta. Now, this if these are some of the tricky questions which might be asked in practical examination, and that is why I have included this slide. Are dichorionic diamniotic twins always dizygotic? Or can monozygotic twins be dichorionic diamniotic? So it is same thing whatever we have seen in the previous two slides. Dichorionic diamniotic twins can be either dizygotic or monozygotic. We have already seen division occurs within first 3 days. It will be dichorionic diamniotic even if it is a monozygotic pregnancy. Monozygotic twins can be DCDA. Dizygotic twins are usually DCDA, that is dichorionic diamniotic. If division of fertilized ovum or cell mass occurs in first 3 days, then only monozygotic twins are dichorionic diamniotic. It is the repetition of whatever we have seen in the previous slides. Now, certain rare variations in the types of twins are monozygotic might not be identical. Though we call it as monozygotic as identical, and we consider that always the babies will be having same genetic material and will be exactly looking same, that is a misconception. Sometimes they might not be identical because of unequal split or variation in the genetic expression. Genetic matter itself can get split unequally. That will lead to the monozygotic twins not being identical, or even if the genes are same, the genetic expression might be different, and that might lead to the monozygotic twins being non looking as non-identical. Rarely dizygotic twins are monochorionic. The exact mechanism why it occurs is not known. Now, there is another rare condition which is called as sesquizygotic twins. Sesquizygotic twins, where they share 100% genes from one parent but 50% from another parent. Here, there is a one ovum which is getting fertilized with two sperms. That is also called as dispermic fertilization. These are this type of pregnancy. It is very rare. Only two documented cases are present in literature till date. Dizygotic twins have same or different sex, whereas monozygotic twins are always of same sex. Only exception is rarely one baby with monozygotic might be 46XY male and other might be 46X0 Turner female with the loss of Y chromosome. That is a rare occurrence. Usually monozygotic twins are of same sex. Superfecundation is whenever there is a heteropaternity might be there, that is fertilization by two separate sperms from two separate individuals where two ova are fertilized by two sperms at a separate time. Superfetation is there is a gap of one menstrual cycle in between the two implantations or two twins, and it is mostly because of assisted reproductive technology. Now, why chorionicity is more important than zygosity in multifetal gestation is the most important question, and it is the most important concept. And I want all of you to focus on this concept because it answers the main um, important concept really related to this topic. So, why chorionicity is more important than zygosity? Complication rate is only slightly greater with monozygotic twins pregnancy as compared to dizygotic dichorionic twin pregnancy. Monozygotic and dichorionic twins, the complication rate is 20%, and dizygotic dichorionic twin pregnancy complication rate is 10%. So zygosity is affecting, but it is slightly increasing the complication rate. But fetal growth restriction, preterm delivery, perinatal mortality rate are more with monochorionic than dichorionic pregnancy, irrespective of zygosity. So if it is monochorionic, complication rate is 70%, whereas with dichorionic, complication rate is 15%. So such a drastic jump is there from 15 to 70% if we compare the monochorionic pregnancies with the dichorionic pregnancy. Whereas if we compare zygosity, monozygotic 20% is the complication rate, whereas dizygotic 10% is the complication rate. So difference is there, but it is not significant. Significant difference is whenever there is a change in chorionicity. Monochorionic 70% complication rate, dichorionic 15% complication rate. That is the main reason why chorionicity plays a greater role in the outcome of a twin multifetal pregnancy as compared to zygosity. Complication rate is maximum with monochorionic monoamniotic pregnancy, and especially with conjoined twins, complications are even worse, more. Placental vascular anastomosis are absent in dichorionic, whereas these anastomosis are maximum with monochorionic pregnancy. Chorionicity impacts adverse perinatal outcome more than zygosity. So what is happening with monochorionic is it is a shared placenta, one placenta being shared by two babies, and even whether it is diamniotic or monoamniotic, still the placental sharing will always be there, and that is the reason monochorionic twin pregnancies are associated with greater complications as compared to dichorionic pregnancies. So how we decide chorionicity and amnionicity is on amnionicity is on the basis of ultrasonography. So how ultrasonographically we can know the chorionicity and amnionicity? UAG should be done preferably in first trimester, but before 14 weeks. The best time which is given by some guidelines is 11 to 14 weeks, whereas other guidelines are recommending that it should be done before 12 weeks of pregnancy to know chorionicity and amnionicity. Here, first is we have to identify the number of placentae. Two separate placentae suggest dichorionic, diamniotic pregnancy. Once we see the placenta, two placenta being present at two separate sites, that clears the doubt about the chorionicity. It tells us that it is a dichorionic, diamniotic pregnancy, and it is a it is this dichorionicity will be associated with less complications as compared to monochorionicity. Dichorionic can have fused placenta looking as single. We have already seen previously that dichorionic, though two placenta are there, they might look as single because these are fused sometimes. So single placenta is there. We have to then focus on, we have to see whether there is an amniotic membrane which is visible in between the two fetuses. And if it is present, it suggests diamnionicity. Once we identify the amniotic membrane, we have to focus on site of insertion of this amniotic membrane to the placenta. So like that, ultrasonographically, we have to go stepwise. First step is to see how many placenta we can see. Single placenta, then we have to see whether we can visualize the amniotic membrane between the two babies. If amniotic membrane is present, next is we have to focus on the site of insertion of this amniotic membrane to the placenta. Here, if chorionic tissue is entering in the two layers of amniotic membrane, it leads to thickening of this amniotic membrane, intervening membrane. Amniotic membrane thickness of greater than or equal to 2 millimeters suggests dichorionicity. It suggests it is a dichorionic diamniotic type of a pregnancy, twin pregnancy. On the other hand, amniotic membrane thickness of less than 2 millimeters suggests monochorionic diamniotic twins. Absence of amniotic membrane suggests monochorionic monoamniotic twin pregnancy. Now, sometimes this thin amniotic membrane of less than 2 millimeters is sometimes not visualized in early pregnancy, and we have to wait till second trimester where we can identify the presence of this amniotic membrane, which is thin with a monochorionic diamniotic twin pregnancy. But whenever amniotic membrane is not seen even in the second trimester, we can diagnose the pregnancy as a monochorionic monoamniotic pregnancy. Now, what is T sign? What is twin peak, lambda or delta sign? That is a very commonly asked question. T sign is amniotic membrane thickness is this here. Now we can see clearly that this is a single placenta here as well as here. So both situations we have a monochorionic pregnancy. When it is monochorionic, there is a single placenta, we have to see whether we can see the amniotic membrane. So amniotic membrane is visible, and if it is thin membrane with thickness less than 2 millimeter, we have to focus at the site of insertion of this membrane to the placenta. And here, if it creates a T shape, then it is called as a T sign. And T sign is suggestive of presence of a monochorionic diamniotic pregnancy. On the other hand, what is twin peak, lambda or delta sign is here when we see the single placenta, which might be a fused or a two separate fused placenta or really a monochorionic pregnancy. Then we have to see whether there is a intervening membrane. If membrane is there and it is a thick membrane with a thickness which is intervening membrane greater than or equal to 2 millimeters, so we have to focus at the site of insertion of this membrane to the placenta. And here, if we can see a triangular tissue, triangle at insertion of this amniotic membrane to the placenta, this triangular tissue suggests that chorionic tissue is present, the chorionic layer is present in between these two amniotic layers, and this is called as a twin peak sign, delta sign or lambda sign, which suggests that it is a dichorionic diamniotic pregnancy. So whenever it is a single placenta, we have to see whether there is a membrane. Intervening membrane is thin, we have to see at the site of the insertion to the placenta. If it is forming a T, it is suggestive of monochorionic diamniotic pregnancy. If there is a triangular placental tissue is seen entering into the two amniotic layers, then it is suggestive of a dichorionic diamniotic pregnancy. I hope it is clear to you that T sign is suggestive of monochorionic pregnancy. Delta, lambda or twin peak sign is suggestive of a dichorionic diamniotic pregnancy. In both of these situations, there are two amniotic sacs. It is a diamniotic pregnancy. Only difference is whether it is a monochorionic in T sign with a T sign or dichorionic with a twin peak, delta or lambda positive sign. So again, approach to determine chorionicity and amnionicity and zygosity by ultrasonography in multifetal pregnancy. Ultrasonography should be done at 11 to 14 weeks. Step 1 is we have to see for number of placenta, whether it is there are two or whether it is single. If two number of placenta is 2, it is dichorionic diamniotic pregnancy. If it is one single, we have to next step is to see for amniotic membrane. Amniotic membrane is absent even in second trimester, then it is suggestive of a monochorionic monoamniotic type of a pregnancy. If amniotic membrane is present and it is thin, even in second trimester, is usually seen in second trimester, then it is monochorionic diamniotic. If it is a thick amniotic intervening membrane, Then it suggests presence of fused placentae, where then twin peak sign, lambda or delta sign will be positive, and it is suggestive of dichorionic diamniotic pregnancy. Whenever it is a dichorionic diamniotic pregnancy, next is we can go for a determination of the sex of the babies, and different sex of the babies suggestive of dizygotic pregnancy. Same sex is suggestive of dizygotic or monozygotic pregnancy. So that is how now this sex determination and declaration of the sex is legally not uh, uh, it is illegal to declare the sex of the babies in many countries, including India. So this step is only relevant for the countries where sex determination is ultrasonographic sex determination and declaration is legally allowed. There only we can go for this step 4. If we compare dizygotic with monozygotic pregnancy, 80% of the twin pregnancies are dizygotic, 20% are monozygotic. Dizygotic is almost always dichorionic diamniotic type of a pregnancy, whereas with monozygotic it can be monochorionic diamniotic, which is most common. 75% of the monozygotic are monochorionic diamniotic. Dichorionic diamniotic is around 24% and less than 1% are monochorionic monoamniotic. So remember that in monozygotic, monochorionic diamniotic is most common. Dichorionic diamniotic is less common as compared to monochorionic diamniotic, and least common, rarest is monochorionic monoamniotic. In our career, usually we don't see many cases of monochorionic monoamniotic twin pregnancy because out of all these monozygotic itself is only contributing for 20%, and out of that less than 1% are monochorionic monoamniotic. Incidence of dizygotic twins differs depending on the race, age, ART use, family history, various factors which affect the incidence of dizygotic twins, whereas monozygotic, there is a constant frequency of 1 in 250. Better offset outcome overall is seen with dizygotic, whereas outcome is less favorable with monozygotic twin pregnancy, and it worsens from dichorionic diamniotic is slightly better. Then it worsens in with monochorionic diamniotic, and the least or poor outcome will be with monoamniotic chorionic monoamniotic, and that too with the conjoined twins. Now, why should we diagnose multifetal gestation preferably in early pregnancy? Ultrasonography in first trimester is more accurate. Accuracy is greater to determine gestational age, chorionicity, and amnionicity. This accuracy reduces with advancing pregnancy. Chorionicity accuracy is 98% in first trimester, 95% before 24 weeks, and only 90% after 24 weeks. So it is better to do see for this T sign, lambda sign in before this 12 weeks of pregnancy in first trimester itself, because the accuracy is 98%. Early diagnosis helps to deal with associated complications because of the multifetal pregnancy in early pregnancy. Aspirin, if to be started, we can start it for prevention of preeclampsia in appropriate cases. And we have to sometimes we have to determine the number of fetuses and take a decision SOS or if necessary about the fetal reduction. And that is why we should be diagnosing multiple gestation in early pregnancy, preferably in first trimester. What is the role of ultrasonography in multifetal pregnancy? It is to determine number of babies, to determine the gestational age, chorionicity, amnionicity, where UAG is done from 11 to 14 weeks with a crown rump length of 45 to 84 millimeters. Gestational age estimation is done as per the crown rump length of the largest baby. One should assign nomenclature to each baby such as upper and lower or right and left, or fetus A is the nomenclature usually given to the lower fetus. Sonography is repeated at least monthly interval, or some of the guidelines do recommend ultrasonography every 3 weeks after 22 weeks of pregnancy for especially for fetal monitoring to diagnose fetal growth restriction or twin to twin transfusion syndrome at the earliest. One can use transvaginal sonography if transabdominal sonography is inconclusive because of a retroverted uterus or obesity to determine chorionicity and amnionicity. There is no role of 3D ultrasonography in cases of twin or multifetal pregnancy. Complications of multifetal pregnancy, all the major topics in obstetrics are getting covered. If we see the list of complications, that is how you can even remember the complications also. Whole of the obstetrics is getting covered. Antepartum spontaneous abortion and vanishing twin, increase in congenital malformations, hyperemesis gravidarum, preeclampsia. Now, congenital malformations, remember that these are more with the monozygotic twin pregnancy, and especially monochorionic twins. Monochorionic, monoamniotic, there is further increase in congenital malformations. Hyperemesis gravidarum with increase in beta ICG, preeclampsia, preterm labor and pre-labor rupture of membranes, fetal growth restrictions or discordant growth, fetal demise, demise of one or both the babies in a twin pregnancy, anemia complicating pregnancy, complications peculiar to monochorionic and monoamniotic twins, intrapartum uterine contractile dysfunction, abnormal presentation, cord prolapse, and increase in operative delivery. Postpartum hemorrhage. Postpartum complications, especially low birth weight babies are there. Second twin is usually having a poor outcome as compared to first. Breastfeeding problems are usually seen with these babies because of the low birth weight, prematurity, as well as the maternal exhaustion with feeding the baby, both the babies, and that is why these problems might arise. Lactation, related to lactation also. Complications peculiar to monochorionic, when the placenta is being shared by both the babies, there are vascular anastomosis. Whenever it is a single placenta, both babies are sharing a single placenta, vascular anastomosis are present, which lead to, these are the we will see later on, but twin to twin transfusion syndrome, twin where there is a anemia polycythemia sequence, and here there is a twin reversal of perfusion, arterial perfusion sequence. Twin to twin transfusion syndrome and discordant growth are not synonymous. This is important concept, that whenever there is a discordant C in the growth, that is not necessarily be similar, maybe that pregnancy might not be having necessarily twin to twin transfusion syndrome. These two are not same terminologies, these are different. Discordant growth is seen with monochorionic as well as dichorionic pregnancy, whereas TTTS, twin to twin transfusion syndrome, is specially seen with monochorionic twins. That is how you can remember that every discordant growth is not because of TTTS. TTTS might lead to discordancy, but there are other causes also, other factors also which might lead to discordancy in the growth, and that is why these two terminologies are separate. We'll see later on how it differs. Complications peculiar to monoamniotic, where both the babies, there is no intervening membrane, only one gestational sac, and both the babies are there. High fetal loss rate is up to 50%. Spontaneous abortion, congenital anomalies, especially cardiac anomalies. Preterm birth is more common. Twin to twin transfusion syndrome is less than with monochorionic diamniotic pregnancy. Surprisingly, with monoamniotic pregnancy, TTTS is less, and the reason which is given is usually the anastomosis are between artery to artery, whereas whenever there is a artery to vein, arterial AV anastomosis, which are more commonly seen with these diamniotic type of pregnancies, then the twin to twin transfusion syndrome is more commonly observed. Discordant growth can also be seen, and cord entanglement is peculiar to monoamniotic, which cannot be predicted by Doppler, but it can be diagnosed by Doppler. What is twin to twin transfusion syndrome? It occurs in 10 to 15% of monochorionic twins in mid pregnancy. There is a donor twin and there is a recipient twin. Donor twin is donating the blood to the recipient twin so that the donor twin becomes anemic, growth restricted. There is hypovolemia, oliguria leading to oligohydramnios, leading to stuck twin. Contractures and pulmonary hypoplasia might occur because of severe oligohydramnios. On the other hand, exact opposite is recipient twin where there is a polycythemia. Occlusive complications because of hyperviscosity might be seen. Volume overload leads to polyuria. Severe hydramnios. Heart failure can occur. Hydrops can develop and there can be premature rupture of membranes. How we diagnose twin to twin transfusion syndrome? It is based on two ultrasonographic criteria. First is diagnosis of monochorionic twin pregnancy where single placenta will be observed. Second is we have to focus on deep vertical pocket to know the how about the amniotic fluid. One the DVP greater than 8 centimeters and another less than 2 centimeters. One baby having oligohydramnios, another baby having polyhydramnios, that is suggested, and with a difference, so much of difference in between these two is suggestive of twin to twin transfusion syndrome. So if, without doing any other studies, what we are focusing on is how much is the amniotic fluid, because whenever there is a donor twin is there, babies one baby is donating blood to the other literally. If there is hypovolemia, there is less urine output and oligohydramnios. So best way to diagnose twin to twin transfusion syndrome is to focus on how much is the amniotic fluid in both the sacs. One baby is having oligohydramnios with deep vertical pocket less than 2 centimeters. Another baby is having polyhydramnios with deep vertical pocket greater than 8 centimeters. Along with monochorionic twin pregnancy is diagnostic of twin to twin transfusion syndrome. If it is pregnancy is less than 20 weeks. Whenever it is greater than 20 weeks, then this DVP should be to diagnose polyhydramnios, it should be deepest vertical pocket should be of the size of greater than 10 centimeters. Growth discordancy is not necessary for diagnosis of twin to twin transfusion syndrome is most important concept. I want all of you to understand that growth discordancy is not necessary to diagnose twin to twin transfusion syndrome. What is important is discrepancy in the amount of amniotic fluid. UAG monitoring every 15 days is to be done in monochorionic twins from 16 weeks onwards to diagnose twin to twin transfusion syndrome at the earliest. Whenever deep vertical pocket difference is greater than 4 centimeters, then weekly monitoring with umbilical artery Doppler is to be done to know whether the babies are suffering. Now, fetal brain damage occurs in 8% of TTTS, and this brain damage is more if there is a death of one of the babies. Immediate delivery, even if immediate delivery of the second baby is done, still this brain damage cannot be prevented because whatever damage occurs is instantly when the one baby dies, there is a shift in the pressure in the vascular channel so that major blood is getting shifted from live baby to the dead baby, and that is how the live baby undergoes this brain damage. And this brain damage cannot be prevented even by immediate delivery because it occurs immediately. Instant changes there leading to irreversible brain damage. There is a Quintero staging given in 1999 for this TTTS, where stage 1 is urine is visible in the bladder of donor twin. Stage 2 is urine is not visible in donor bladder. Stage 3 is there is associated abnormal Doppler study in umbilical artery, ductus venosus or umbilical vein. Stage 4 is there is ascites or frank hydrops in any one of the twin. And stage 5 is demise of any one of the twin. Treatment of TTTS is by laser ablation, which gives better results as compared to amnioreduction, where you remove the excess of amniotic fluid from the sac, which has polyhydramnios. Or selective fetal reduction is also has also been tried, where the baby which is suffering maximally is there is a selective fetal reduction which is done, but the results are not very good for surviving twin, and the best results are at present seen with the laser ablation. Various presentations of chronic fetal vascular anastomosis in monochorionic twins are we have already seen in the previous slide, but in detail. TTTS is twin to twin transfusion syndrome leading to polyoli. It is called as polyoli because there is a polyhydramnios and oligohydramnios. Blood is transfused from donor to the recipient twin. It occurs in 10 to 15% of monochorionic twin pregnancies. Monochorionic are themselves are only 15% of all the multifetal pregnancy. And out of these 15%, only 10 to 15% of these the 15% are having twin to twin transfusion syndrome. That way, it is not a very common complication. TAPS is twin anemia polycythemia sequence. Here, for diagnosis, there is a role of middle cerebral artery, peak systolic velocity. There is no polyoli hydramnios with TAPS. It can be spontaneous rarely, but usually it is iatrogenic after laser treatment of TTTS. It is observed in only 1 to 6% of monochorionic pregnancies. TRAP is twin reverse arterial perfusion sequence or a cardiac twinning. It is very rare, 1 in 35,000 pregnancies. Deoxygenated blood is transmitted to the receiver twin, and that blood is only going to the iliac vessels and lower extremity and leading to development of only lower extremity and ill development of the upper part of the body. That is why it is called as a cardiac twinning. And its treatment which is given is early detection and radio frequency ablation. Now we come to discordancy, growth discordancy. So what are discordant twins? It is the usually this is diagnosed as ultrasonography diagnosis in second trimester or from second trimester onwards by calculating estimated fetal weight. Fetal weight discordancy is usually given in percentage as with a formula as estimated fetal weight of larger minus that of smaller divided by estimated fetal weight of larger fetus into 100. This is the formula to calculate the growth discordancy, and it is diagnosed, it is called as a discordant growth whenever it is discordancy is greater than discordance of greater than 20%, then it is called as discordant twins as per ACOG 2021. Some of the guidelines are taking the cutoff point as 25%. Management is we have to monitor the baby with NST biophysical profile, and umbilical artery Doppler plays a major role whenever there is a monochorionic pregnancy. Now, as we have already seen, a discordant twin might be seen with monochorionic as well as with dichorionic twin uh, type of a pregnancy. Timely termination is important step in management. Now, what are the causes of discordant twins? 50% of all twin pregnancies, whether it is monochorionic or dichorionic, go for discordancy. Perinatal mortality rate increases with increasing discordancy, especially as it is greater than 25%, more will be the mortality rate, greater than 40%, further increase is there in the perinatal mortality rate. If the discordancy occurs earlier in pregnancy, such as less than 20 weeks, there it is associated with greater perinatal death rate. So, what are the causes of discordant twins? It can occur with monochorionic or with dichorionic type of pregnancy. With monochorionic, TTTS leads to the discordancy, or there can be discordant structural anomalies with a monochorionic that can also lead to the development of discordant twins. Discordant structural anomalies is one baby is having some structural abnormality whereas other is not having. This discordancy will in the structural anomalies will lead to the difference in the growth, that is called as discordancy. With dichorionic, different genetic growth potential can be there, or because there are the placental site is unfavorable for one baby as compared to the other because of overcrowding, and that can also be the reason for this discordant growth even in spite of having a dichorionic pregnancy. Now, another terminology which is given in NICE 2024 update is selective growth restriction. Selective growth restriction is where there is a restricted growth of only one fetus. It is diagnosed when one baby is having less than third centile for gestational age, estimated fetal weight, or any two of the three. Discordance greater than 25%. One baby estimated fetal weight less than 10th centile for gestational age, or abnormal umbilical artery Doppler in smaller baby. In other words, we want to see every only less than 10 percentile of estimated baby weight for gestational age. That one criteria is not sufficient to say there is a growth restriction, because we know that some babies are having less birth weight, but they are constitutionally small. There is no abnormality. There is a physiologically they are smaller ones because of the genetic potential itself having leading to a smaller baby. So to differentiate between these babies which are constitutionally small or those which are having some pathology, this criteria is important. Now there is further division of this growth restriction is done with the umbilical artery Doppler, as type 1 as normal Doppler finding, type 2 persistence of absent end diastolic flow, and type 3 is intermittently if we can see absent or reverse diastolic flow, and it is given that the outcome is poor with type 2 as compared to type 3 because there is a persistent absent end diastolic flow in type 2. If there is a complete molar pregnancy with coexisting normal fetus, usually termination is the treatment. But expectant management is also been tried by some of the studies. So it is also an option. Risk of GTN, gestational trophoblastic neoplasm, does not increase with expectant management. Pregnancy needs monitoring for preeclampsia, antepartum hemorrhage, thyrotoxicosis, and hyperemesis. Gravidarum whenever there is a complete molar pregnancy associated with a normal fetus, and when the termination is not done and pregnancy is managed with a expectant line of management. Now, what is the impact of death of one fetus in a twin pregnancy, or why we should diagnose a vanishing twin is? Vanishing twin is death is occurring in first trimester, early pregnancy. 10 to 40% of all twin pregnancies go for vanishing twin. It leads to adverse effect on biomarkers and cell-free fetal DNA if fetal demise occurs after 9 weeks. This is important concept. It leads to fetus compressus or fetus papyraceus if death of one fetus occurs in early second trimester. First trimester, it leads to vanishing twin, but second trimester, it will lead to fetus compressus or fetus papyraceus. Importance of vanishing twin is its adverse effect on test for the detection of chromosomal abnormalities, because it leads to increase in biomarkers, and even it leads to false positive finding in cell-free fetal DNA. Death of one fetus is called as single intrauterine fetal death, SIUFD. If it occurs after 20 weeks, then preterm delivery in the second baby, intrauterine death of the surviving baby, neurological injury to the of the second baby, all these risk increases for the second baby. In monochorionic, death or neurological abnormality in other babies more as compared to dichorionic. 15 to 30% is the risk if there is a death of one baby with a monochorionic, and it occurs because of acute hypovolemia with blood shift to dead fetus through anastomosis. we have already seen in the previous slide, this is not preventable by immediate termination of pregnancy. And if this occurs and baby is not, second baby is already not viable, termination might be considered, because the permanent brain damage is a neurological abnormality, is a great, is a higher risk is there whenever it is a monochorionic pregnancy. Otherwise, we can deliver the co-twin by 36 weeks by keeping the pregnancy under close monitoring. DIC is very rare after the death of one baby, because usually the whatever the thromboplastin like substances are being secreted by the dead after the death from the placental tissue. These are usually are getting compensated by the normal functioning of the second placenta, and that is why even after the death of one, it is a very rare complication, maternal DIC. What what additional care you will provide in antenatal period to a woman with multiple pregnancy? Prevention and early detection with treatment of anemia, CBC to be done in each trimester, extra calcium supplementation, more frequent ANC visits. Digital vaginal examination is advocated by NICE guideline for cervical shortening or dilatation. I'm sorry, not by NICE, but by Williams is advocated for cervical shortening or dilatation. Additional calorie intake of 40 kilocalories per kg per day with twin pregnancy. Screening for chromosomal abnormalities should be done, as there is increased risk of chromosomal abnormalities, and it is done as a for initially as a combined test followed by, or we can go as contingent test as cell-free DNA. Anomaly scan and fetal echo, especially with monochorionic pregnancy. Ultrasonography to screen for fetal growth restriction every 3 weeks with deep vertical pocket measurement. Antepartum fetal surveillance by NST BPP weekly after 32 weeks in monochorionic, and after 36 weeks in dichorionic pregnancy. What is the role of aspirin in multifetal pregnancy? Start aspirin from 12 weeks of pregnancy till delivery in all cases is given by Williams, but there is a difference of opinion, and especially NICE guideline or RCOG guideline 2024 update is recommending that these are the cases where we should be giving aspirin with multifetal pregnancy, as any two of the following moderate risk factors. One factor is already multifetal pregnancy. Along with that, nulliparity, obesity, family history of preeclampsia, age greater than 40 years, pregnancy interval greater than 10 years. Or we have to start aspirin with any one major risk factor, whether there is a multifetal pregnancy or singleton pregnancy. Whenever there is a previous pregnancy with a history of hypertensive disorders in pregnancy, chronic hypertension, diabetes type 1 or type 2, chronic kidney disease, or autoimmune disease such as SLE or APLA, antiphospholipid syndrome. So this, I think it is a, this chart should be in every obstetric OPD. So many times we do miss this opportunity to start timely aspirin if we do not remember the these major risk factors. Usually we do remember and we do start, but this moderate risk factors presence of any two, sometimes we do miss that, and that is why I think this should be, this chart is a must in each obstetric OPD. Otherwise, if we go as per Williams obstetric textbook of obstetrics, it is advising as per Williams, it advises starting aspirin in each case of multifetal pregnancy from 12 weeks till delivery. Dose with a dose of 75 to 150 milligram per day. Now, how will you do screening for chromosomal abnormalities in multifetal pregnancy? Combined screening to be done. Combined is you go for NT scan, that is nuchal translucency, free beta HCG, and PAPPA, pregnancy associated plasma protein A. It should be done at 11 weeks. For some reason it is missed, then we can go for quadruple test in second trimester, beta HCG, estriol, AFP, and inhibin. Now, NIPT or this cell-free fetal DNA is can be used as a contingent test. Contingent is if the first trimester combined test is positive, then directly instead of going for invasive testing such as chorion villus sampling or amniocentesis, we can go for this cell-free fetal DNA. That is called as contingent testing. So this is what has been recommended. We have to remember that whenever there is a there is a case where there is a vanishing twin, that one fetus dies in first trimester and then repeat ultrasonography shows only one no, if previously USG showing twin pregnancy and then repeat you do and it shows singleton pregnancy is suggestive of a vanishing twin. If this death of the baby in first trimester occurs after 9 weeks, it might lead to raise and misleading biomarkers, especially plasma pregnancy associated plasma protein A, as well as this maternal serum alpha fetoprotein and inhibin A. All these are raised if the death of the one of the baby occurs after 9 weeks. And there is an increase in the false positivity for cell-free fetal DNA that we have to remember whenever it is a case of vanishing twin. Now, how will you prevent preterm labor in a case of multifetal pregnancy? We know that there are some of the factors which are considered as predictors for preterm labor, and we should be screening for those. Screening for preterm labor as per NICE for predictors. We have to do the measurement of cervical length by ultrasonography at 16 to 20 weeks. ACOG differs here that according to ACOG, it is not of much use to do the measurement of cervical length by ultrasonography. But NICE guideline is advocating that we should go for that from 16 to 20 weeks. And anytime cervical length is less than 25 millimeters, we should start progesterone vaginal capsules 200 milligram at night till 34 weeks of pregnancy. Whereas ACOG says that there is a questionable place for this progesterone supplementation for prevention of preterm labor in cases of multifetal pregnancy. Anytime you do this, suppose you miss to do the cervical length measurement from 16 to 20 weeks and you do it from 20 to 24 weeks, and now the length is less than 25 millimeters, you can offer the same. Here you definitely start, here you might offer. There is no role of fetal fibronectin level measurement to predict preterm birth in twins. No role of intramuscular progesterone, Arabian pessary, bed rest, oral tocolytics, or cervical cerclage as per NICE guideline 2024. There is a role of rescue cervical cerclage with prophylactic antibiotics and indomethacin whenever there is a cervical dilatation at less than 24 weeks of pregnancy, is as per some of the uh, studies. So there is a very limited role for cervical cerclage as per these guidelines in a case of multifetal pregnancy. Now, if preterm labor occurs or if there is a PPROM, how you proceed is in preterm labor, tocolytic therapy has got a questionable place because there is a possibility of greater maternal complications with a multifetal pregnancy than a singleton whenever we are using tocolytic drugs such as pulmonary edema, maternal tachycardia. Corticosteroids are to be given same policies same as for singleton pregnancy. If there is a PPROM, usually delivery is advisable within 4 days. If there is a preterm premature pre-labor rupture of membranes. Now, whether if there is delivery of one baby and second baby is in utero, should we wait for a delayed delivery of the second twin with preterm labor is there is a questionable place, because in that case there is a risk of intrauterine infection. There is a risk that that second baby might have neurological damage also, and that is why it has a questionable place. If you are asked what is the optimum timing of delivery in a twin pregnancy, it depends on what is the type of twin. If it is dichorionic, diamniotic, uncomplicated pregnancy, Then termination can be done by 37 weeks as per NICE guideline, by 38.0 by 7 to 38.6 by 7 as per ACOG. If it is monochorionic, diamniotic uncomplicated, usually the pregnancy termination is advised by 36 weeks with the use of corticosteroid. Chorionic monoamniotic termination is usually uh, is advised by 32 to 34 weeks with the corticosteroid course. Now, route of delivery in a twin pregnancy, indications for vaginal delivery. Clear indication is when both the babies are bicephalic presentation, CC. First bicephalic, second also bicephalic. Here, after the delivery of the first, we have to again reconfirm the presentation of the second by abdominal examination, vaginal examination, and if there is a doubt, by intrapartum ultrasonography. If there is a cessation of contractions and no recurrence of uterine activity, we have to start dilute oxytocin drip and deliver the second baby at the earliest. Now, if it will be with a first baby is by cephalic. Now, if first baby and second is also by cephalic, but if first is by cephalic and second is non-cephalic, that means it is either cephalic with breech or cephalic with transverse line. In these cases, various options are cesarean section, elective cesarean section. Second is vaginal delivery of the first, followed by either internal podalic version or external cephalic version of the second, or vaginal delivery of the first, followed by cesarean section for second. And cesarean section is usually necessary because there might be abruption, cord prolapse, or closed cervix. Abruption is because of the sudden reduction in the size of the uterus, placental separation occurs before the delivery of the second, and that is the reason where there can be a uh, necessity to do the emergency cesarean section for delivery of the second, or the second baby might be having features of fetal distress. But remember that whenever we go for this option, vaginal delivery for first, followed by cesarean section for the second, the perinatal outcome is worst as compared to other scenarios. So all these options are discussed, and it is depending on the individual case. We have to take a decision whenever it is a first cephalic and second non-cephalic. It depends on the experience of the obstetrician also to conduct a breech delivery, to perform a internal podalic version, external cephalic version, and also to monitor and go for a quick cesarean section if there is a problem. Clear indications for cesarean section will be first baby is non-cephalic, discordant twins, all monochorionic monoamniotic twins. In a case of previous cesarean section, again there is a question mark. Some of the guidelines are advocating trial of labor after cesarean section, whereas others are, most of the guidelines are going for elective repeat cesarean section. If second baby fails to deliver for greater than 20 minutes after the delivery of first baby, it is also an indication for cesarean section. Greater is the interval between the delivery of first and second baby, poor is the perinatal outcome for second baby. What additional steps we have to take in whenever a patient is in labor? Transfer the patient should be at a tertiary care center with all the facilities. IV line should be there and slow IV fluids are to be given. Adequate blood should be kept ready. Intrapartum ultrasonography facility, anesthesia facility, and there should be facility or provision of 2 neonatologists. Place of induction or augmentation with oxytocin is questionable. Some of the reports are showing that there is increase in the risk of uterine rupture and postpartum hemorrhage. Other reports are showing better results with the induction or augmentation. So there is, at present, it is inconclusive, we can say. The evidence is inconclusive. Prevention of PPH, always go for active management of third stage of labor. What is active management? What you do is, in case of a normal delivery, give 10 units oxytocin intramuscularly after delivery of the last baby, but before clamping and cutting the cord. With a cesarean section, 5 units intravenous oxytocin to be given after delivery of last baby, but before cord is clamped and cut. What are the indications for reducing number of fetuses in multifetal gestation? There are different terminologies. One is multifetal pregnancy reduction or MRP. Here it is to reduce the number of the babies to improve the outcome in which it is done in late first trimester. Selective reduction is where reduction of abnormal fetus is done in late first trimester. Selective termination is reduction of abnormal fetus in second trimester. There is how it is done is injection of potassium chloride in fetal heart or fetal thorax, but there is a risk of complications in remaining fetuses or fetus, as well as risk of maternal complications because of this procedure. Thank you so much. I have taken help of Williams Obstetrics mainly, along with NICE Guideline 2024 update and FOXY 2024 update on management of multifetal pregnancy. Thank you once again.